once we have detected an abnormal signal in the skin, which could be clinical or pathological, the clinician should evaluate the blood looking for abnormal cells. In the past, we used to do a CBC, a complete blood count, and find out, number one, if the patient presents with what we call lymphocytosis, or an increased number of lymphocytes, which is a red flag that you may be dealing with Sézary syndrome. And when we detected something abnormal in the CBC, we would do a review of the smear. So a smear of the blood and simply counting lymphocytes. How many abnormal cells are there? Sézary cells are morphologically very distinct from benign lymphocytes. Even though they may be small or medium sized, they have what we call hyperconvoluted, very regular nuclear membrane that those cells can be counted. So under the microscope, a histotech would count several hundreds of cells and find out whether this is Sézary syndrome or not. Now, nowadays, the way we detect it is not so much morphologically, but sending the blood that has shown something abnormal to flow cytometry. And flow cytometry will show us whether the T cells express markers that are typically retained in normal T cells, especially CD7 and CD27. Flow cytometry will also let us know if the ratio of T helper, CD4, T suppressor, CD8 cells is within normal limits or abnormal. One of the findings that defines Sézary syndrome is the presence of a CD4, CD8 ratio extremely high, over 10:1. So ideally, we check a panel with multiple markers that define B cells like CD20, T cells, CD3, lymphocytes in general, CD45, and then we look at the subsets of helper, suppressor, NK cells, and then those markers that may define Sézary syndrome, which are CD7 and CD26.